In this video, we're gonna talk about inflammatory bowel disease. It is an autoimmune disorder that involves chronic inflammation of GIT. There are further two types, ulcerative colitis and Crohn's disease. Ulcerative colitis is a long-term condition where the colon and rectum become inflamed. The colon is the large intestine and the rectum is the end of the bowel where the poo is stored. Small ulcers can develop on the colon's lining and can bleed and produce pus. It is a continuous inflammation. In contrast, Crohn's disease is inflammatory bowel disease that causes chronic inflammation of your GI tract which extends from your stomach all the way down to your anus, where the sections of bowel are inflamed while other sections remain normal, creating a skip pattern called skip lesion. Common symptoms of IBD include diarrhea, sometimes with blood or mucus, abdominal pain, weight loss, fever, fatigue, nausea, and bloating. Now we'll discuss about the management of IBD. First is to reduce the inflammation. We have two types of drugs in this, aminosalicylate and glucocorticoids. Aminosalicylates reduce the inflammation in digestive tract and they can be taken as pills, enemas or suppositories. It works by decreasing the inflammatory mediators in our body such as interleukin-7, TNF-alpha or leukotrienes. In this class, we have sulfasalazine, mesalamine, olsalazine, and balsalicide. Sulfasalazine broke down in the colon by bacteria into its active components 5-aminosalicylic acid and sulfapyridine, use the production of inflammatory mediators like prostaglandins, thus helping to decrease the inflammation in the colon. Salamine works by inhibiting the production of inflammatory mediators, though the suppression of cyclooxygenase and lipoxygenase pathway, thereby reducing the inflammation. It came as delayed release capsule or pH-dependent tablet, so it is released in colons and not in the GI. Salazine is a prodrug of mesalamine, so works by the same mode of action, and so is the balsalicide. The glucocorticoids also work by decreasing inflammation and used for short-term treatment. It includes prednisolone, hydrocortisone, and its prolonged use can cause renal suppression, osteoporosis, and hyperglycemia. Now for the removal of infection in IBD, we use antibiotics that decrease the harmful bacteria, protect against the infection, and remove the inflammation. Includes metronidazole, clarithromycin, and ciprofloxacin. For decreasing the immune response, we have immunosuppressants and biological DMARDs. Azathioprine, 6-mercaptopurine, methotrexate, and cyclosporins inhibit the antibody production, thus in decreasing the immune response. Biological DMARDs such as omalizumab and adalimumab target specific inflammatory molecules TNF to suppress the overactive immune response in the gut. Now we will discuss inflammatory bowel syndrome, that is different from the inflammatory bowel disease. IBS does not cause inflammation while IBD does. In this, a person experiences both episodes of diarrhea and constipation, often alternating between the two bowel movements. For treating diarrhea, we use loperamide and diphenoxylate, which is 5-HT3 antagonist. Alocetrone has long duration of action. Its adverse effects include GI toxicity, constipation, and ischemic colitis. For treating constipation, we have 5-HT4 antagonist that is tagacerod, but it causes QT prolongation arrhythmia. And the second option is bulk laxatives, which include methylcellulose and psyllium. If not, consider giving lubiprostol and linaclotide, that is chloride channel activator, but its side effects include GI symptoms. For the pain, we use rifaximin. Rifaximin is short-term use in IBS, IBD. And antispasmodics and tricyclic antidepressants. Antispasmodics include dicyclomine, hyoscyamin, that are antimuscarinic that cause dry mouth and drowsiness. Tricyclic antidepressants include imipramine and amitriptyline. See you in my next video. Till then, subscribe, like, share, and comment.